Alright, so are you ready for part 2 of the X-ray interpretation? It's not just going to be X-rays, we're also, the second part we're going to be talking about MRIs, PET scans, CT scan, so just other imaging. Alright, so when we're looking at congestive heart failure, I kind of want to go right to the picture of it, and I'll kind of go through the pictures or the narrative part while you're looking at the picture itself. Okay, so basically we have redistribution of pulmonary vasculature with an engorgement of the upper lobe vessels. Okay, so generally an X-ray is going to look kind of fluffy. It might have like this, they might call it fluffy. It looks wet basically. Has this fluffy kind of appearance to it. So generally the normal chest produced image shows the pulmonary blood vessels most prominent in the lower lobes. And the left side heart failure, when left side heart failure happens, or CHF, this increases venous pressure, and the increased pressure then distends the upper lobe vessels that would otherwise carry very little blood. Okay, so when you have this engorgement of these vessels, then you're able to see them. They're more prominent on the X-ray when you have that extra fluid. Okay, so this will be on 207 in your textbook. Fluid collection is in the dependent portions of the lung, and on this X-ray you're going to see this increased width of the heart in relationship to the thorax. So you can see how wide the white part is here. Okay, so normally the base of the heart occupies only about half of the width of the thorax, and in congestive heart failure this ratio is going to increase, where the heart obviously appears much larger here in this film. Increases in the width of the shadows of the mediastinal structures is another sign of fluid overload. And then they're kind of hard to see. It says here they're really hard to reproduce on print, but you'll have the curly B lines. So just remember curly B lines, K-E-R-L-E-Y, curly. Those are, if you see curly B lines, that's generally signs of CHF. Okay, and I know that's on a test someplace. So these lines are usually seen more so in the right base, and are generally less than 1 millimeter thick and approximately 1 to 2 centimeters in length. So you develop these curly B lines that are generally seen in the right base. Again, they are less than 1 millimeter thick and approximately 1 to 2 centimeters in length. They are horizontal and start at the periphery, and then they extend to the lung approximately to 1 to 2 centimeters. They are basically pleural lymphatic vessels that are filled with fluid. They're generally very subtle. They're often hard to see on an image, and it says only is nearly impossible to reproduce in print. Some of the other things that you might see here are increased interstitial markings caused by fluid collection around the lymph channels, kind of in the middle here. The pleural effusion is greater on the right hemothorax, and on the left you have more fluid, kind of like in here. Enlarged pulmonary artery segments caused by increased pulmonary artery pressures. The fluid collection around the vessels causes the margins all to be blurred, and you have this fluffy perihilar opacities caused by the fluid collection in the lung tissues. So it just kind of looks like someone took maybe some cotton or cotton candy and kind of made it get really thin, and that kind of fluffy, like hazy like appearance. So how is your patient going to present when they're in CHF? I mean, we have an X-ray to diagnose them, but we also have some other telltale signs. Generally they have those fine inspiratory crackles. Sometimes they can really, if they have a lot of fluid, they can have like a audible tracheal kind of wheeze. Their heart rate's usually up. It can be regular or irregular. They might have some jugular vein distension in their neck. They may have an enlarged liver. They may have the hepatojugular reflex where the doctor kind of pushes down on their liver below their ribs there, and when they push on it, then the vein distends in their neck, and also ankle edema. Alright, so back to talking a little bit more about the pleural effusion. As far as some of this is a little bit of a review of what we talked about, but generally a pleural effusion, I mean, we can detect them quite small, but generally they're greater than 100 mils. So a small volume effusion is going to cause that blunting where you're not going to be able to see the costophrenic angle. Okay, so you're not going to see that sharpness. You might have that small meniscus sign, which is kind of like that little dip, kind of like, not quite like a new moon, but just a real slice, like a sliver, like maybe like an orange slice, maybe just that kind of little dip. A partially obscured and maybe a elevated hemidiaphragm. Again, it depends on the size of it. A large effusion can actually show a complete whiteout of the side of the lung that's affected, and it can completely obscure the hemidiaphragm. Of course, you need to confirm it with a lateral film, so having them lying on their side. And then again, kind of a review of what you might get, the type of fluid if you're going to do a thoracentesis or try to get the fluid out. A transudate then is going to be generally more clearish. It says almost always free flowing. You're going to have that low protein count, and the transudate generally is due to the extra fluid. So you've got CHF or hepatic failure. You can also accumulate with atelectasis. And then exudate is yucky. It's got the high protein content, can be loculated or compartmentalized, like it's just kind of in that one area, and generally associated with some type of infection. So you might have an abscess, could be related to pneumonia, sometimes it's malignancy. And if that's the case, if it's malignancy, pleural effusions, they generally reaccumulate. Highly likelihood of them reaccumulating. With the infectious one, hopefully if they can treat the infection, it won't reaccumulate, but malignant pleural effusions always reaccumulate. TB and fungal infections, just from, I don't know if I may have told you guys, but my brother, he had lung cancer, and then he developed pleural effusions, and he had a chest tube in just because it just kept reaccumulating and reaccumulating and reaccumulating, and he could not, he was getting end stage, and he couldn't take the pain of the chest tube always being in. He didn't want to go home with the chest tube, so he ended up having the chest tube taken out, and just went to hospice because it was just kind of his time. So a lot of times if someone's like, yeah, I've had this happen before, it's like, ugh, you just kind of want to cringe, like, I hope don't say anything because that's not our job, but highly likelihood it could be a malignant pleural effusion. Alright, just again some other views where you can kind of see here. I would say definitely on the right side, maybe not on the left, probably be a good idea to do a lateral film on the image on the left, and then obviously on the right image on the left lung, that would be a total whiteout. And then again, having them lying on their side to able to separate out that fluid. Some of the physical findings, you're going to have dullness to percussion in the areas, gophony just above the area of dullness, because it'll be kind of like a space. There might be tachypnic, decreased or absent breath sounds on the affected side. Okay, so thoracentesis, so that's generally where they put a small needle into the pleural, well, it might not be that small, but it's just a temporary placement. They just put the needle in to drain the effusion out and to kind of see what the pleural fluid is made up of. They send it out to lab and then kind of go from there to decide treatment. Pericardiocentesis is where they're going to actually do, again, a needle placement, but into the sac surrounding the heart to get off that fluid, because again, if you have a really large pericardiocentesis, you don't want a tamponade. So it's really important to get that fluid off, and then again to see why is it there. And then a bronchoscopy is another way to approach. It looks for a pneumothorax after if you've had a transbronchial bronchoscopy or a needle aspiration. So pretty much after any of these procedures, a thoracentesis, the pericardiocentesis, and then if you do a bronch, you definitely want to do a chest x-ray to make sure that you haven't poked anything. So generally we do the bronch, to actually obtain a biopsy or secretions or see what's going on in the lung itself, getting out, tissues or secretion or whatever. Sometimes if we do take that biopsy, then we have the risk for an air leak and then a pneumothorax. So if we've gone in to do a transbronchial biopsy, or we've actually gone in with a needle and either snipped off a piece or aspirated off something, then we definitely need to make sure that we do a chest x-ray after these procedures to make sure the lung is still inflated. Alright, CT scan. CT is someplace you'll go fairly frequently, and it's interesting. I was kind of reading in the textbook about MRIs. It says aren't done that often. Well, at Good Sam's they are. They seem to take everybody and their brother down to CT for sure, and then even a trip to MRI if they're uncertain what they're looking at. So the nice thing is that they really have advanced the technology of the CT scan, so it literally takes longer to get the patient down there, to move the patient onto the table, to get everything situated than it does to actually do the scan itself. The scans are really, really quick now. So basically a CT takes like slices. It's a high resolution pictures with like 1 to 2 millimeters thick. So can show very fine details. You can actually inject contrast where it gives you a better idea of the vessels that allows for like a CT angio, or looking at heart disease or PE, ruling out a PE. It's pretty much taken over. We don't usually do VQ scans anymore, which I'll talk about in a couple slides. You also have the 3D format, which is used for needle aspirations or different catheter placements. So CT is a big time tool. The high resolution can detect very small tumors at about 2 millimeters. They also again guide for needle biopsies if we have to have a procedure. The CT can show tissue masses that are hidden by dense tissues on otherwise on a plain X-ray, and it can help them differentiate between lymph nodes from tumor masses. It's also used to help diagnose mild pulmonary fibrosis, along with diffuse interstitial lung disease, things that we might not see in a regular X-ray. It can actually help identify over 100 different disease types. In HIV or AIDS, it can help detect if they're having abscesses or cavities or different pneumonias and lymphomas. So you'll definitely be going to CT. I have to say though, we do the CT of the chest, but we do a lot of CT of the heads to see if someone's had a bleed, or if they're, a trauma. They always go to CT to kind of look at their head and their spine and their chest. So again, a CT is much clearer and more detailed than a chest X-ray. It has a 90% accuracy of diagnosing COPD, and where compared to a chest X-ray, it only has about 65 to 80% accuracy. So it's much more accurate. You can kind of see those blebs and those over-distended areas on the CT. Other things that they may be looking for are occupational related diseases. So hint, hint, if you have COPD as your study, or your ClinSim, or interstitial lung diseases, fibrosis, any of these conditions here, you may want to include a CT as part of your evaluation or your test that you're going to have done. Could my family be any more louder? We're looking at different pneumococciniosis, nodules, pulmonary fibrosis, asbestos. You can see pleural plaques, again pneumonia and bronchiectasis. All right, MRIs. MRI uses this nuclear magnetic resonance. Now, resonance, I guess is how you say it. One thing about the MRI, you have to be very careful when you go in there because it is basically a large magnet. So there is protocol to be followed where in the CT scan you can, it's a little bit easier to go in and get your patient set up and everything, and you just need to leave the room or put lead on when they actually turn the scanner on. In the the MRI room, you are not going to be in there unless there's something funky going on. Oops, darn it, I hate it. I touched my screen. I was cleaning up some dust. Not touch it. It's really super loud when they turn that machine on. And then plus all the protocols that are involved, you have to make sure you don't have any metals on. Rings and that are okay, but best to, if you're wearing a lab jacket or whatever, like I always do, to take off your lab jacket because you're gonna, I always have stuff in my pockets like scissors and that type of thing. Pagers, watches, phones, obviously, of course we don't really have pagers anymore, your stethoscope, and then the big deal with taking them into CT or MRI is that we have to switch. Once they get down there, they have to switch all their leads on their chest. They have to change the pump over for their IVs. They have to put everything onto MRI compatible devices. We have a ventilator that's MRI compatible, all that kind of stuff. So it's quite the process to get them all switched over to everything, and then you have your MRI person that's down there from radiology, and they're very knowledgeable and they definitely help. But just it seems like more and more the last couple of years I worked with nurses that were new, and some of the MRI people and the CT people are like, they were so glad to see me because they knew that I knew what was going on, where a lot of those new nurses was like, oh my god, it was a nightmare. But anyway, just be really, double check everything before you go in there. And they do have a sensor that'll kind of like alarm, but still, you don't want that to have to happen. So anyway, it's a great tool. Like I said, I think you're going to see it used a fair amount. You can generate these really thin sections, images of any part of the body, including the heart, the veins, the arteries, from any angle and direction. And unlike the CT scan, the MRI, again, it's a headache to kind of get them all set up and get them in there, but it takes a while. Once they get in there, they're usually in there for a good 30 to 45 minutes, sometimes longer. So it's the preferred scan for diseases of the brain and the central nervous system, looking for mediastinal and hilar masses, chest wall invasion, also used for complicated pleural and diaphragmatic disease. A lot of times it's head, sometimes like the chest and the abdomen. It can show necrotic tumors, lymph nodes in the hilar region, keeping in mind that breathing causes artifact, but basically any time that the only reason I'm going down there is because my patient's on a vent, so I have to make sure everything's, and even their pulse ox probe needs to be changed. Everything needs to be changed. So the breathing is fairly well controlled. We usually sedate them for the procedure because it's so loud, and they have to have earplugs in. Alright, so this is something that they really don't do anymore. They used to. The lung scans, the ventilation perfusion scans, basically they have a It provides a picture of the blood flow to the lungs. So they inject a dye. They also inhale something, radiopharmaceuticals, so the radioactive are either injected and inhaled into the bloodstream or the lungs. Again, these are not used hardly at all anymore to see whether or not they have a pulmonary embolism. So what has been replaced with the spiral, the helical or spiral CT scan, which kind of gives them the 3D with the contrast. So that's basically has replaced the VQ scan. It's less invasive. It's just as accurate. So you can kind of see here as they're inhaling the different the radionucleotides or the radiopharmaceuticals, how they're inhaling that. I'm trying to look. So this one here, trying to see if this matches the one in the book. It's really hard to read these. But the ones that have a lot of color to them, basically, that are dark, is showing that these are normal lung scans. So there's no evidence of perfusion defects. So they look at the anterior, the posterior, the oblique, and the lateral views. And then the perfusion, they obviously are checking for blood clots, so they kind of see if it matches up, ventilation and perfusion. Pulmonary angiography, that is actually one where it's going to require a catheter into the pulmonary artery. This is done only if VQ scan and then the CT angiogram with the contrast is non-diagnostic and the patient's a high risk for a PE. It's also done if there is actually, they know that there's a clot and that it needs to be treated. So they thread a catheter into the vein, into the right side of the heart, and into the pulmonary valves, into the pulmonary artery, where then they inject a contrast medium into the pulmonary artery and see how it branches off. So, of course, because they can get what they need from the CT, they generally don't do this anymore because, again, it is an invasive procedure. Now, PET scan is another. I haven't been to a PET scan for a long time. This is generally used to diagnose like cancer. So, so you see these little kind of spots that show up, and basically the patient fasts for several hours. Then they're injected with a radiopharmaceutical labeled sugar water. They need to remain supine and quiet for about an hour, and then the metabolically active tissue takes up the sugar water, and then it appears black on the film, and they refer to those as hot spots. So they don't want your metabolism to be increased or anything, because they want the hot spots, the cancer cells, to kind of take up that sugar water and then be able to show up on the scan. Apparently it's not helpful to diagnose brain metastasis because the brain is too active. So I found that kind of interesting. So PET scans are generally used to diagnose cancer. Alright, I'm going to talk a little bit about the technical quality of the X-rays. Now, a lot of this part you're going to kind of go over as you watch those videos that are on those different lessons. So you're looking at the exposure. Again, this is generally the radiologist's job, or the rad tech's job, to make sure that they have taken a good picture. But things that you're looking at are, you want to make sure that you can see the vertebral bodies, easily seen if it's overexposed, because then your lungs are totally black in contrast. Underexposed, then the lung fields look more white, and then it's more difficult to differentiate between the vertebral bodies and the whiteness of the underexposed film. So you want to make sure you can identify those. So you're looking at the different exposure of the film, but hopefully if they recognize that it's not exposed right, that they'll redo it. So an MRE question, you want to be able to see at least 10 ribs for expansion to make sure you have a good inspiration. Okay, so that's part of the technique that the radiology person does if they're shooting an X-ray on a patient that's spontaneously breathing. They tell them take a deep breath in and kind of hold it and let it go because they want that good inspiration. Sometimes they will, obviously they are familiar with the ventilators and they try to time it, with the breath. Sometimes if you're in the ER and you just intubated a patient, they want to do a chest X-ray. You're often left in there with the rad tech because you might not have the vent hooked up quite yet. Back in the old days, it seemed like we bagged our patients for a CT and stuff. But anyway, make sure you put your lead on, and then the radiology tech might ask you to give a good squeeze, and then they'll shoot the film. So you're actually responsible for getting that good breath in. So, because if you have a poor inspiration, your heart is going to look larger than it truly is. So it's important. Important. Okay, now again, we kind of talked about this before. You want to make sure your lines are placed where they're supposed to be. Your ET tube about 3 to 5 centimeters above the carina, or T4, T5. Making sure if they're putting in a swan or a pulmonary artery catheter, the same thing, that it's in the right place, or the CVP is in the right place, that it's in the right atrium. Okay, so a normal chest X-ray, if there is an increased, here, this is an MRE question. I'm trying to make sense of my notes here. So on your MRE2, if there is an increased cardiothoracic ratio, it is a sign of what? Okay, so if you have an increased cardiac thoracic ratio on your chest X-ray, so your heart looks bigger than it should, you should pick the answer, or write the answer of CHF, okay, congestive heart failure. So here is a picture of a normal X-ray where our lung fields are dark, it's symmetrical. Your heart then is less than 1/2 as wide as your chest. Okay, so if it's greater than 1/2 as wide, as we mentioned before in those previous films, then it could be CHF. Your trachea is midline to down to T4. Your diaphragm dome is a little bit higher on your right than on your left because of your liver. And you have a good costophrenic angle. It's hard to see a little bit on that left side because the picture's kind of cut off. But again, lung fields are dark, so we're looking more at the densities here. Your heart, diaphragm, and blood vessels, or the water density, or the whitish gray. You have your ribs, clavicle, and scapula, or vertebrae are showing up kind of white, so that's normal. So yeah, your heart, your diaphragm, and your major blood vessels are considered to have the same density of water. So remembering that lung consolidation due to pneumonia, tumors, or collapsed area is actually going to absorb more of that X-ray, and it's going to appear white and patchy on the film. Cavities or blebs, they're going to absorb fewer X-rays, so those are going to appear darker. So you'll be going through all of the systematic approach on those lessons on the chest X-rays. So again, A, you're looking at your airways, making sure your trachea is midline. B, bones, your ribs should be equidistant apart. So your You're looking there at your left anterior first rib. On number 2, you're looking at your left posterior 6th rib. And then your number 3, which is hard to see on this, you're looking at your left 6th costophrenic angle. And then, I'm trying to see, is this on your textbook? I don't think this one's on your textbook. But you'll get some good examples too in those lessons. That's why I think they're a good resource. Let's see, so then number 4 looks like, which is probably on your lowest one on the right, looks like your left anterior 6th rib, and then 5 would be your right posterior 12th rib. So again, making sure that you have that equal distance. You're looking at the heart and the heart borders, making sure that they are distinct and that you don't see any signs of cardiac silhouette. Make sure you have right border, the 2 notches or bulges. The blurring might be a right middle lobe pneumonia. On the left side, you should have 3 bulges, the aorta, the pulmonary artery, and the left ventricle. Depends on your films, and it's kind of funny because now you actually don't get real films like the X-ray film itself. It's on like special plastic, like almost paper. Everything's on the computer. So, all right. Then you're looking at your diaphragm. Make sure you're looking at your costophrenic angles, keeping in mind that your right side's going to be higher than your left. The esophagus is going to be behind your trachea, that you're going to have fissures. Those are best seen on your lateral views. The gastric bubble is going to be seen on your left. Okay, and I want to say that might be a quiz question. The other thing I want to say is making sure that you remember what the flattened diaphragm, what disease process that's indicating. I hope you should know. COPD. Right. Let's see. I want to make sure I'm hitting everything in the notes here too. Looking for curly lines, because that's going to be indicating CHF. Sometimes they will have a collapsed right middle lobe, which can be seen in asthma or maybe displaced fissure lines, loss of aeration with atelectasis. Really hard to differentiate between the lobes. It's kind of more like where you anatomically on the outside kind of know where they are. And then your mediastinal area, what that looks like. Nodules are generally less than 1 centimeter, are considered benign. Now, keep in mind, radiologists, they interpret X-rays, but we have we should be able to, again, recognize the trachea, making sure our ET tube's in good placement, whether they might have a pneumothorax, whether the X-ray looks wet, making sure you see your costophrenic angles, some of the bigger things. So the nodules, some of them contain calcium, which are usually benign. If it's a malignancy, it's probably going to get change in size. Looking for over aeration, like a darker color on the film, indicating emphysema. Also, possibly, what they're admitted with, there's some type of a foreign body causing air trapping. Again, I mentioned the costophrenic angles, looking for making sure those aren't blunted, because that could indicate a pleural effusion. And then, of course, a pneumothorax. And this is again just part of the puzzle, part of all the pieces of the puzzle to kind of help diagnose, what's going on with your patient, trying to put all the pieces together. Okay, I'm just looking here at my notes. I want to make sure I talked about this part already, but lastly, I want to talk about Again, the air bronchograms, because I do believe there's an MRE question on this coming up, or an exam question. So an air bronchogram, again, is a tubular outline of an airway made visible by the filling of the surrounding alveoli by fluid or inflammatory exudates. So again, an air bronchogram is a tubular outline of an airway made visible by filling of the surrounding alveoli by fluid or inflammatory exudates. So some of the processes that could cause this would be a lung consolidation, pulmonary edema, non-obstructive pulmonary atelectasis, interstitial lung disease, a neoplasma, and even normal expiration. I thought that was interesting, because I have did some research on the air bronchograms. I mean, the book talks about it a little bit, but it was something that I really forgot that I had learned at some point. But yeah, so those are the kind of the 6 ones I have listed. I think I might ask you to list a couple reasons. Might even be a bonus question, I can't remember. But lung consolidation, pulmonary edema, non-obstructive pulmonary atelectasis, severe interstitial disease, the neoplasma, and even normal expiration. Okay, so that does it for today. Again, this is Tuesday's lecture. You also have an exam today that I have posted that should have been available, or will be available depending when you decide to listen to this. It's available from 5 in the morning on Tuesday until midnight. All right, see you next time.